Okay, hi, I'm Gabriel, and as you can see here, I'm a year 4 medical student. For those of you who are my friends in medical school, hi, if you happen to be seeing this. You'll probably be wondering why I'm coming up with an approach to clinical conditions and why dysphagia. Because actually what happens is that now for us in NUS, we're having a pathology exam coming up in about 3 weeks time, and as I'm going through some of the textbook stuff, I also find that we're having some clinical approaches, and refreshing it is quite good for us because that's one thing that's not really covered in our text as well, not really covered very well in our standard text as well as in our lectures. So sit back, relax, and comment. This is meant to be me sharing my approach. It's not a be all and end all. Yeah. So without further ado, I'll just show you some of the sources I use. As you can see here, this is from Up to Date. This is an approach to dysphagia which I use. It's not bad. Up to Date is not a bad place for approaches, and as you can see, sometimes I use my family medicine books as well for my approaches because I'm interested in family medicine. Of course, I really have to credit Dr. Andre Tan. He's actually, I believe, an MO in medicine now, who came up with some really good surgery notes for the MBBS, which I used as well. So kudos to him. Alright, so now without further ado, I'll have to start on my approach to dysphagia. Unfortunately, I can't put it all in one video because YouTube has this stupid policy of stopping your videos at 10 minutes because they have some weird problem with the stupid uploads. So okay, here goes. Before we start, I have an outline here. I'm gonna introduce and define what dysphagia is. Then after that, before we have any approach, we must always know the possible causes before we can approach anything. So I'll be talking about the causes. Then after that, the main bulk of the sharing will be about how we approach it clinically by our history, our physical investigations, and I have these two really helpful algorithms from Up to Date which I will share with you guys. Lastly, because I'm kind of interested in primary care, so I'll talk about the indications for referral for dysphagia, and then of course the references. Alright, introduction and definition. How do we define dysphagia? As we all know, dysphagia is to doctors as well as to laymen a difficulty with swallowing. But the nice way to define it is a subjective sensation of presence of an organic abnormality in the passage of liquids or solids from the oral cavity to the stomach. The keywords are subjective sensation as well as organic abnormality of passage of liquids or solids. It's derived from Greek, where dys is difficulty and phagia is to eat. Why is it that dysphagia is difficulty in eating whilst odynophagia is pain on eating, whereas dysmenorrhea is pain on menstruation? I don't know. You have to ask the Greeks that. What's important to note is that dysphagia is an alarm symptom. That's why I'm covering this first. Of course, it's also because I'm studying my esophageal pathology first, then followed by the gastric pathology after this. But that's also one reason why I'm covering it. It's an alarm symptom, so it's really important to evaluate immediately as well as institute appropriate therapy. Another point is not to attribute dysphagia just to simple aging, because it's really not normal. In aging, you get a reduction in motility that is rarely symptomatic, if at all. Okay, so no old person should be having dysphagia. Maybe they have a bit of decreased saliva, but not dysphagia. Right, now we move on to the causes. Dysphagia classically is classified by its symptoms into whether it's oropharyngeal or esophageal. I've included the last category here called functional dysphagia, where no organic cause is found despite extensive investigations. This is not really like an important category to worry about. The important thing is to differentiate whether it's oropharyngeal or esophageal, because our management as well as evaluation varies greatly in terms of the kind of investigations, even history and physical, that we do. For oropharyngeal dysphagia, it classically occurs when there is a difficulty on initiation of swallowing, as opposed to esophageal dysphagia, where the problem with swallowing is actually found several seconds after the food gets stuck, and they feel it somewhere at the suprasternal notch or in the retrosternal area. The causes are broadly divided into mechanical and neuromuscular causes for each of the above classifications of dysphagia. So in other words, you can have esophageal mechanical causes, esophageal neuromuscular causes, oropharyngeal mechanical, oropharyngeal neuromuscular. So an example of an esophageal mechanical cause will be a peptic stricture or esophageal cancer. The causes of like mechanical and neuromuscular can be further divided into whether it's for mechanical, whether it's benign versus malignant, so like a peptic stricture versus esophageal cancer, whether it's a luminal versus an intramural versus an extramural cause. I guess you know that when you talk about any obstruction, you divide into whether it's in the lumen, in the wall, or outside the wall. Okay? For neuromuscular, you divide into whether it's in the central nervous system, the peripheral nervous system, and the last one actually, which I forgot, is at the muscles level, like example in a muscular dystrophy or something. So for a central nervous system neuromuscular cause, it could be like a CVA or Parkinson's. Here's a broad overview of the classification and causes of dysphagia. I'll bring it closer so you all can see. Don't worry, for your benefit, I've proceeded to like kind of break this down into two separate slides. This has been shamelessly copied from Dr. Andre Tan's book. The causes of oropharyngeal dysphagia, like I said, can be divided into whether it's neuromuscular or mechanical lesions, otherwise known as obstructive. Okay, I have bolded the big bananas. In other words, those that we should focus on. Stroke, Parkinson's, brainstem tumors, these things are, stroke and Parkinson's are common. The rest are not common, but amongst them, like the ones that are like really like deadly are like what? Brainstem tumors lah. Of course, that's not to say like multiple sclerosis isn't deadly or amyotrophic lateral sclerosis isn't deadly, but these would probably be the more representative causes. For mechanical lesions, here in Asia, tumors of the oropharynx are not that uncommon because of the extension of nasopharyngeal carcinoma. So, someone with oropharyngeal dysphagia, you have to rule out mechanical lesions such as NPC. The other thing to talk about is the Zenker's diverticulum, which is outpouching of the hypopharyngeal mucosa in between the fibers of the cricopharyngeus as well as the inferior constrictor. That part is known as Killian's dehiscence. This is in the surgery books and I won't cover it anymore. But it's something to take note because they have like halitosis and a pouch developing after a meal. So it's a spot diagnosis if you're clever, and I mean not clever, if you're observant and you pick it up. Well, esophageal causes, quickly run through. Neuromuscular versus obstructive. Neuromuscular causes usually are problems with motility. So like achalasia, where there's impaired relaxation of the lower esophageal sphincter, as well as disordered peristalsis, and this is usually due to an unknown cause. What's important to note that sometimes there is actually this thing called pseudo or secondary achalasia, where cancers can produce achalasia, or not just cancers like Chagas disease also, anything that affects the neurons can result in an achalasia-like picture. So like esophageal cancer could actually present as a neuromuscular cause in terms of symptomatology. So it's important to note. Obstructive lesions,